Namaste Vidya.
Namaste sir.
A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science, JAYOTI VIDYAPEETH-FHS. In the last lecture, we have discussed about rheumatoid arthritis. We have discussed different factors. So today we are going to first revise all the things that we have discussed, and then we are going to start with the rheumatoid arthritis in continuation with the last lecture. So what is rheumatoid arthritis? First of all, you tell me this thing.
Chronic inflammatory arthritis with multiple system disorder.
Joints, basically small joints are involved. Okay. What is the age group that is most commonly affected?
25 to 55 years old.
25 to 55 years age. The individuals are more commonly affected. Sex incidence, it is more common in
Female.
than in
Male.
Alright. Now, what are the factors? What is the cause? What is the etiology of rheumatoid arthritis? Exact etiology is not known. Alright, it is unknown, but there are certain factors that are associated with the development of rheumatoid arthritis. Alright. So, what are the factors? Number one,
Smoke, genetic factor, environmental factor.
genetic factors. What are the genes that are associated with it?
HLA-DR4.
HLA-DR4. Other environmental factors.
Smoking and other microbiome.
Smoking is directly related to the development of rheumatoid arthritis. Now, what are the symptoms? What are the clinical features of rheumatoid arthritis?
Stiffness. More than 1 hour.
Swelling. This is basically an inflammatory disease. So all the signs of inflammation are present. Alright. Smaller joints are affected. Bilaterally symmetrical joints. What are the other symptoms of?
Last for more than 1 hour.
Yes, there is morning stiffness that lasts for more than 1 hour. What are the other clinical features?
Constitutional symptoms. Weight loss, fatigue, malaise, occasionally low-grade fever.
Low-grade fever, malaise. There are some deformities about which we discussed in the last class. Can you tell me the deformities?
Ulnar deviation.
First one was
Ulnar deviation.
flexor. That was also known as
Trigger finger.
the next one was
Swan neck.
swan neck deformity. What was there in swan neck deformity? There was
Hyperextension of PIP.
proximal interphalangeal joint and
Flexion of
interphalangeal joint. Exactly opposite to the swan neck rigidity that we had. Both artery deformity. What was there in both artery deformity? Flexion of the
proximal interphalangeal joint.
Hyperextension of the Very good. What was the other deformity?
Z deformities.
Deformity. That was related to the thumb.
Thumb.
The other deformity? Ulnar deviation of the hand. Next? Piano key movement. Next?
Gamekeeper thumb. Gamekeeper.
Very good. So these were the different deformities that we discussed.
Flat foot.
Now, rheumatoid arthritis is not only affecting the joints, but it is also affecting extra-articular manifestations. So, extra-articular manifestations are seen in which organs?
Cardio, neuralgia.
Very good, sclera. So, there are various places at which you can see the extra-articular manifestations. In the last lecture, we have discussed about the articular manifestations. Today, we are going to discuss about the extra-articular manifestations. So, let's start with the extra-articular manifestations now. Extra-articular manifestations develops during the clinical course of rheumatoid arthritis. So, as and when the rheumatoid arthritis is progressing, we can see the extra-articular manifestations. Alright, prior to the onset of rheumatoid arthritis. So, before the onset of arthritis, you can also see extra-articular manifestations in the individual. Patients have a history of early onset of physical disability. So, there is early onset of physical disability and the patient is positive for rheumatoid factor. So, rheumatoid factor is a very important factor that is seen in case of diagnosis of rheumatoid arthritis. The common manifestations of the extra-articular disease consist of subcutaneous nodules, secondary Sjögren's syndrome, pulmonary nodules, and anemia. we have discussed yesterday that the degree of anemia is coincides with the degree of inflammation. The more the inflammation, the more is the anemia. And this can be confirmed by which two tests? ESR and CRP protein levels. More the level of the ESR, more the level of the CRP protein, more is the anemia. And as the treatment begins, as the levels lower down, the degree of anemia is also reduced. This will come in the consecutive slides. Now, these are the various extraarticular manifestations which can be seen in this picture. We have neurological changes, hematological changes, changes in the gastrointestinal tract. We have skeletal changes, ocular manifestations, oral manifestations, endocrine, and the skin. So there are different organs that are affected due to rheumatoid arthritis. Or rheumatoid arthritis is having its action on the following organs. Okay? Now, what are the symptoms? What are the clinical features of the extraarticular manifestation in case of rheumatoid arthritis? First of all, we have constitutional symptoms. The constitutional symptoms includes weight loss, fever, fatigue, depression, and severe disease. Cachexia. Cachexia, what is the meaning of cachexia? This is basically anemia. Okay, anemia like symptom. Then nodules. Nodules are seen subcutaneously. There are subcutaneous nodules which are present in this case. Generally, these are firm and non-tender. These are not painful to touch and adhering to the periosteum. The tendons or bursa due to the repeated trauma. Alright. Or irritation in forearm and sacral prominences. Now we have Sjogren's syndrome, which consists of the presence of dry eye, dry mouth. Dry eye is known as keratoconjunctivitis sicca, and dry mouth is known as xerostonia. So we have dry eyes, dry mouth. Alright. In association with the other connective tissue disease, which occurs in 10% of the patients with RA. So you will see in many patients of rheumatoid arthritis, long-standing cases of rheumatoid arthritis, that eventually they develop dry eyes and dry mouth. Alright, the eyes becomes dry, absolutely dry, and there is no tear formation in the eye, due to which they have to put regular eye drops in order to make the eyes moist. What will happen if the eye remains dry? Ulcers, very good. You will have corneal ulcerations if no tear formation is taking place. Now, pulmonary manifestations consist of, most of the common pulmonary manifestations is pleuritis. So, pleuritis is the most common pulmonary manifestation that is seen in case of rheumatoid arthritis. It presents with pleuritic chest pain. So, you have pleuritic chest pain, you have dyspnea, and as well as pleuritic friction rub and effusion. There is interstitial lung disease. What was present in interstitial lung disease? I told you yesterday. Dry cough and it is progressive shortness of breath. So we have dry cough and progressive shortness of the breath that is present. Pulmonary nodules may be solitary or multiple. So you get subcutaneous nodules, you get pulmonary nodules in case of rheumatoid arthritis as an extraarticular manifestation. Now there are some cardiac manifestations. In cardiac manifestations, the clinical manifestation of pericarditis. You will also observe pericarditis in 10% of the patients. Cardiomyopathies are other clinically important manifestations. Mitral regurgitation. This I have also told you yesterday that mitral regurgitation is also very common presentation in the patient with rheumatoid arthritis. Alright. So in 10% of the cases, you will also find cardiac manifestations in the patients with rheumatoid arthritis. Next we have vasculitis. Vasculitis is the inflammation of blood vessels. So this typically occurs in the patient with long-standing disease. All the extraarticular manifestations are most commonly seen in the patient with a long-standing disease because the disease is affecting at a very young age. Alright. So as the disease progresses, you will find a lot of affections of this particular disease and on multiple organs of the body. And due to which deaths are very common. Alright, in the last lecture we have discussed that the mortality rate is very high with long-standing cases of rheumatoid arthritis, and also the disability rates are also very high. The cutaneous sign includes fatigue. Whenever the blood vessels are affected, there will be positive rheumatoid factors, that is a diagnostic feature of rheumatoid arthritis, and also there are cutaneous signs like petechia, purpura. This is bleeding from the blood vessels. When you get petechial hemorrhages, purpura is blood bleeding, and digital infarct with gangrene. So you also get gangrene, and in severe cases, painful lower extremity ulcerations. Because of the lack of blood supply in the lower extremities, these ulcers are very common, ulcers in the lower extremities. Okay. So, and these are very difficult to heal. These type of ulcers are very difficult to heal. There are also hematological factors like normocytic normochromonic anemia. In the extra-articular manifestations of rheumatoid arthritis, we get anemia. Anemia is characterized by normocytic normochromonic anemia, often develops in the patient with rheumatoid arthritis. The degree of anemia, this I have just told you that the degree of anemia correlates with the degree of inflammation. More the inflammation, more is the degree of anemia. And as the treatment begins, as the inflammation reduces, the degree of anemia also reduces in case of rheumatoid arthritis. The level of inflammation can be checked by C-reactive protein and also PSR rate, which represents the degree of inflammation in the body. Now, another extra-articular manifestation of rheumatoid arthritis is Felty syndrome. Felty syndrome is characterized by the triad of neutropenia. Neutropenia, what is neutropenia? Decrease of what count? Neutrophils. We have splenomegaly and nodular rheumatoid arthritis. So, Felty syndrome is characterized by three things. Number one, neutropenia. Second, splenomegaly, and the third one, nodular rheumatoid arthritis. And is seen in less than 1% of the patient. But since this is seen in some of the patients with rheumatoid arthritis, therefore we are discussing it here. Lymphoma. There is 2 to 4-fold increase of lymphomas in the rheumatoid arthritis patient. Most common type is B-cell lymphoma. So, lymphomas are also associated with rheumatoid arthritis, and most common of it is B-cell lymphoma. There are certain neurological complications which are also seen in cases of rheumatoid arthritis. The neurological complications consist of peripheral entrapment neuropathies. There are peripheral entrapment neuropathies from compression by hypertrophied synovium. Since the synovium is getting hypertrophied, due to which the nerves are getting compressed, and this is there is also subluxation of the joint, lateral deviation of the ulna, and subluxation of the joints because of the erosion of the bony surfaces and fusion, ankylosis of the joint, due to which the nerves are getting compressed, and it is resulting in the development of multiple neuropathies. The medial nerve compression in the carpal tunnel syndrome is an early presenting feature. You all must have studied about carpal tunnel syndrome in anatomy first year. Alright? So, carpal tunnel syndrome is also very common manifestation in case of rheumatoid arthritis. Cervical cord compression. Cervical cord can also be compressed and result in subluxation of the cervical spine at the atlantoaxial joint. So these are the various places at which the nerve compression can take place, leading to the development of multiple types of neuropathies. Associated conditions in addition to the extra-articular manifestations. So these were different extra-articular manifestations. Can you rename those extra-articular manifestations to me once again? We had constitutional symptoms. What were the constitutional symptoms of extra-articular manifestations?
weight loss,
you have seen different types of nodules. Nodules were present at two places. One was subcutaneous and the second one was pulmonary nodule. Okay. Then we have Sjogren's syndrome that is associated with what are the two signs of Sjogren's syndrome? Dry eyes and dry mouth. Dry eyes is also known as keratoconjunctivitis sicca, and dry mouth is Then we have pulmonary extra-articular manifestations. What was present in pulmonary extra-articular manifestation? We have pleuritis, chest pain,
interstitial lung disease.
Characterized by two things. Next, we had cardiac manifestations. What was there in the cardiac manifestation? Pericarditis. One is pericarditis, cardiomyopathy, and mitral regurgitation. Alright, just three things you have to remember. What are the three things? Pericarditis, cardiomyopathy, and mitral regurgitation. That was syndrome. Okay. Then we had vasculitis. Vasculitis was resulting in different hemorrhages. We had purpuras, we had chymosis, and also we had large painful ulcers. Then hematological factors. What are the hematological manifestations? It includes lymphomas. Anemia. This is anemia. Anemia that is correlating to the degree of inflammation. More the inflammation, more the anemia. What was the type of anemia that the patient is having? Alright. More the inflammation, more the anemia. Less the inflammation, less is the severity of anemia. Then fatty syndrome. Fatty syndrome is characterized by triad of three things. Number one,
Neutropenia, splenomegaly, and nodular.
Next, splenomegaly. And third, nodular rheumatoid arthritis. Lymphoma. Which kind of lymphoma is more common? B-cell lymphoma. Right. Neurological complication due to the compression of nerves, compression of the nerves, and because of the involvement of the nerve roots. So, what are the symptoms? What are the common symptoms? Carpal tunnel syndrome that we should remember. That is most common. Cervical cord compression. There was also associated factors. There are extraarticular manifestations, several conditions that are associated with rheumatoid arthritis. They contribute to disease, morbidity, and mortality. So, apart from these factors, there are also certain associated factors which contributes to the increased morbidity and mortality that is associated with rheumatoid arthritis. Alright, so rheumatoid arthritis is more severe disease than osteoarthritis. Alright, and it is having more severe manifestations. So, what are the other symptoms? Cardiovascular disease, incidence of coronary artery disease, and carotid atherosclerosis is higher in RA patients. Congestive heart failure occurs at an approximately 2-fold increased rate in the patient with RA. So those patients who are having rheumatoid arthritis, there is 2 times more chances for development of congestive heart failure in comparison to the other patients. So the patients with rheumatoid arthritis are more prone for developing different type of cardiovascular diseases, especially rheumatoid congestive heart failure and atherosclerosis. Okay. Now, next is osteoporosis. This is also an important feature that is associated with rheumatoid arthritis. Osteoporosis is more common in patients with rheumatoid arthritis than the age and sex stipulated. Means if a person is having, at a particular age and sex is having rheumatoid arthritis, at the same age, if other individual is taken who is not having rheumatoid arthritis, then the patient with rheumatoid arthritis is more prone for developing osteoporosis. So, with prevalence rate of 20 to 30%, the chronic use of glucocorticoids and disability-related immobility also contributes to osteoporosis. Since due to rheumatoid arthritis, the mobility of the patient is restricted. And also, for the treatment of rheumatoid arthritis, the patient is taking glucocorticoid. These are the other important factors that are contributing in developing osteoporosis. What is osteoporosis?
Softening of the
bone. The bone density is reduced. Then hypoandrogenism. What is hypoandrogenism? Men and post-menopausal women with RA have a lower mean serum testosterone level. So the gonads are also not functioning properly and the production of hormones is also not proper. So mean serum testosterone LH and dihydroepiandrosterone level then control population. So they have a lower hormonal production in comparison to the same age other individuals. So this is also another associated condition. In associated condition we have discussed about cardiovascular disease, we have discussed about osteoporosis, and we have also discussed about the hypoandrogenism. Now, so this was all about the extra-articular manifestation and associated features. Now we come back to the general rheumatoid arthritis, and now we will discuss who are the individuals who are at poor prognosis. What are the features if present in a particular individual describes the poor prognosis of the disease. Means in such patients the disease will be more severe and more resistant for treatment. So, poor prognosis is associated with, if a patient is coming to us with number one, disability. More the disability, the difficult it is to cure the patient with rheumatoid arthritis, and the severity of the disease will be more. So, disability at presentation, female gender. So, if a female is coming to you with rheumatoid arthritis, that means she is more prone for development of the extraarticular manifestations and other complications of rheumatoid arthritis. Involvement of MTP joint. What is MTP joint? Metatarsophalangeal joint. So, if the metatarsophalangeal joint are involved, that is also a poor prognosis. If a patient is smoking, smoking is directly related to the development of complications of rheumatoid arthritis. So, always ask the patient to stop smoking. Positive RF factor and anti-CCP antibodies. So, this is basically a diagnostic feature of rheumatoid arthritis. If these things are present, then these are the poor prognosis conditions. What are the points? Number one,
Disability.
Number one, disability at presentation. Number two,
Female gender.
Third,
Involvement of MTP joint.
fourth,
Smoking.
fifth.
Positive RF factor and anti-CCP.
Very good. So, RF factor and anti-CCP antibodies. Now, this is the comparison. How to compare osteoarthritis and rheumatoid arthritis. Alright, what are the things that can be compared whenever you are studying these two diseases together? Number one, osteoarthritis, and the second one is what is JIA?
Jubilant.
Very good. So, this we will study later on. Alright, juvenile arthritis. Now, osteoarthritis, the symptoms are joint pains. In osteoarthritis, which joints were affected? Usually starting with
One.
single joint and then progressing. Alright. And in rheumatoid arthritis, we have usually
2 or 4 multiple joints.
bilaterally symmetrical joint involvement. Morning stiffness in case of osteoarthritis was
Less than 1 hour.
but in case of rheumatoid arthritis
More than
was
1 hour.
more than 1 hour. The swelling is
Mild.
Usually osteoarthritis is inflammatory or non-inflammatory?
Non-inflammatory.
Non-inflammatory disease. Whereas in comparison to osteoarthritis, rheumatoid arthritis is
Inflammatory.
inflammatory disease where the inflammation was well known. Okay. In osteoarthritis, the symptoms are related to the joints only. Whereas in rheumatoid arthritis, we have seen articular features as well as extra-articular features. Okay. Now, there is no rash, no fever or systemic signs. We have seen the blood indices in case of osteoarthritis will be normal. The ESR will be normal, the blood counts will be normal, and the C-reactive protein will be normal. Whereas all these indices will be disturbed in cases of rheumatoid arthritis. We have pain that causes symptoms osteophytes. Osteophytes is an important feature in case of osteoarthritis. Whereas in rheumatoid arthritis, we have constitutional symptoms like fever, weight loss, there is muscle atrophy, and internal organs are also involved that we have already discussed in case of extraarticular manifestations and associated symptoms. We have seen involvement of the eyes, skin, rashes, nodules, vasculitis, involvement of the lung, heart, and development of the different kinds of wounds. Till here, this is clear to you, rheumatoid arthritis, the extraarticular manifestations. Now let's move forward. How to diagnose the case of rheumatoid arthritis? Whenever a patient is coming to you, the diagnosis is very simple. Since we have studied all the points, now you can easily diagnose the case of rheumatoid arthritis. So diagnosis can be done by the history taking, by asking the symptoms from the patient, what are the symptoms that are present in the patient, and from that history only you can easily diagnose the given condition. So in diagnosis, first of all, morning stiffness. The morning stiffness in rheumatoid arthritis is
More than 1 hour.
more than 1 hour. Alright. And in osteoarthritis it is
Less than 1 hour.
half an hour. It is only around half time. How many joints are involved in rheumatoid arthritis?
3 or 4.
One important thing about the duration of pain, we have discussed in the last lecture, that it is only considered after 6 weeks. And if the duration of pain is less than 6 weeks, then what can be considered? Infective arthritis. Viral arthritis. Alright. Rheumatoid factor present Okay, if rheumatoid factor is present, that means this confirms the diagnosis of rheumatoid arthritis. Radiological changes. What are the radiological changes that can be seen in rheumatoid arthritis? Destruction of the joint and
Osteopenia.
bone. Very good. That was ankylosis, fusion of the joints. And
Joint space narrowing. Sinus formation.
and
Osteopenia.
narrowing of the joint space. Very good. Can you see the nodes?
Yes.
Subluxation of the joints. Arthritis of the hands. Alright, if the hand, the pain starts from the small joint, especially of the hands. Alright, just we have discussed. So, history taking arthritis of the joint. Symmetrical arthritis, this is very important. The same joints of both the sides are usually involved in cases of rheumatoid arthritis. Duration for greater than 6 weeks and rheumatoid nodules that are present in the case. So, we can diagnose the rheumatoid arthritis by following points. Number one is morning stiffness greater than 1 hour. Second one is
Arthritis of the joints.
next
Rheumatoid factor.
present. Fourth
Radiological changes.
fifth
Arthritis of hand joints.
next
Symmetrical arthritis.
duration
More than 6 weeks.
and the last one.
Rheumatoid nodules.
Now, the diagnosis of rheumatoid arthritis is basically it is based on the clinical criteria, and there is no single diagnostic test which can tell you that this is a patient of rheumatoid arthritis. Just by checking the rheumatoid factor, you cannot jump on rheumatoid arthritis. We have to look for all the other clinical criteria that all these should be present in order to diagnose this condition. Swollen and tender joints in the upper limb and knees, and combining this with the ESR and the patient assessment of general health on the visual analog scale. So we have to check for the ESR, we have to check for the C-reactive protein, we have to see the joints and the condition of the joints. The higher the value, the greater is the disease activity. So more and more these values are, the more and more the disease activity and the severity is. So how can you assess the severity of the disease? That we are going to discuss in the next slide. We have disease activity score 28, by which we can diagnose the case and check the severity of the disease. Now, to establish the diagnosis of rheumatoid arthritis, we should have these 4 points. Number one, we should have the clinical criteria that we have just discussed. Alright, there is pain, there is stiffness greater than 6 weeks, the inflammatory signs are present, hands are involved, bilateral joints are involved, and all those features that we have just discussed. So, clinical criteria has to be checked for. Acute phase response. The symptoms in case of rheumatoid arthritis were appearing suddenly, and there were exacerbations and remissions that is present. So we have to check for the acute phase response. What is the response of the body in case of acute phase, and also the involvement of the other organs has to be checked for. We have to go for various serological tests. What are the serological tests that we can go for?
Rheumatoid factor.
RF factor, anti-CCP antibodies, ESR, C-reactive proteins. Alright. So these are the tests that we can do for. X-ray of the affected joint that has to be checked for the presence and development of rheumatoid factor. So to establish the diagnosis, 4 things are important. Number one, clinical criteria. Second is acute phase response. Third is serological test. Fourth is X-rays. Now, how to monitor? This slide basically explains how you can measure or how you can check whether your treatment is effective or not. Whatever treatment you are providing to the patient, whether that particular treatment is causing any relief to the patient or not. So that can be checked by the following things. To monitor the disease activity, we have to check for the following scales. First is the pain. Pain is visual analog scale. When you ask the patient to tell about the pain from 0 to 10 scale. From 0 to 10, just tell me about your pain, how's your pain. That is the visual analog scale. Then early morning stiffness. For how long you had early morning stiffness? Tell me in minutes. That for how much time did you have morning stiffness? When you started your treatment, you had morning stiffness for suppose 90 minutes. Now you are having morning stiffness for 60 minutes or 70 minutes. That means your treatment is in a good direction. Then you also have to go for the joint tenderness. You have to see for the pain in the joint on pressure. Joint swelling, this you have to check for what is the severity of the swelling, whether the joint is inflamed or not, the signs of inflammation are present or not, and what are the other things you have to check for. DAS score, that is disease activity score, you should only know about the name of this score, the details are not necessary for you. Alright, so DAS score 28, disease activity score, and APR is the active phase reaction. So these are the various tests or these are the various things by which you can know the severity of the disease, how the disease is progressing, whether it is the disease is getting better or the disease condition is getting worse. So these are the following conditions. Pain on the visual analog score. We have early morning stiffness in minutes. Next we have joint tenderness, joint swelling, DAS score, disease activity score, and the last one is acute phase. Now investigation to monitor the disease damage, we have to do the X-rays. Repeated X-rays are done to check for the changes that are occurring in the joint. We also have to do the functional assessment of the joint to check for the function, how much function the particular joint is able to perform. To monitor the drug safety, because this is a long-standing disease, the disease is occurring in a very young age in the individual, and for long the patient is taking treatment. So, to check the effect of the medicine that a particular patient is taking, whether it is causing any harmful effect on the kidneys or any other organ, we have to perform certain tests. For drug safety, we have to perform the urine analysis, whether the medicine is coming in the urine or any other abnormality like APC. Biochemistry is routinely done, and hematology. So, urine, hematology and biochemistry, these tests are routinely done to check for the effect of medicine on the body of the patient in order to prevent further complications. Alright. Now investigation, these are basic investigations, some of which you already know. We have ESR and CRP, alright, that denotes the inflammation. Next we have rheumatoid factor, this is a non-specific. Low titers are also found in 10% of the normal population. So as I told you, just if a patient is coming rheumatoid factor positive, you cannot jump on the diagnosis that you are having rheumatoid arthritis, because this test is also present in 10% of the normal individuals who are not having any problem. Plain X-rays of the hands, wrist and feet are useful. Osteoporosis, it is also common in the elderly population. Ultrasound and MRI are more sensitive than X-rays in detecting bone erosion. So if you want to check for the bone erosion, then you have to go for the MRI and ultrasound. The patient with Baker cyst, Doppler ultrasound and arthrogram may be required to establish the diagnosis. So in case of Baker cyst, arthrogram can be done. Now evaluation. How to evaluate? How can you evaluate the condition of rheumatoid arthritis? Evaluation is done by detailed physical examination with a careful examination of all the joints. You have to examine all the joints of the patient in order to evaluate the condition. Rheumatoid factor is present in greater than 66% of the patients. Antibodies to anti-CCP antibodies have similar sensitivity but higher specificity. So if you have to do only one, if you have to perform only one test, then always go for anti-CCP antibodies instead of RFI. Alright, so because this is more specific than RF factor, if you can go for both, then it is very good, but if you want only to perform one test, then anti-CCP antibodies is more specific test. Tendency for developing bone erosion is present most commonly in patients with aggressive disease. So as the disease progresses, there is more and more bone erosion that will be seen in case of patients with rheumatoid arthritis. Radiographs, we have juxta-articular osteopenia, joint space narrowing and marginal erosion. This you already know. So these are the changes that are occurring in the joints. We have juxta-articular osteopenia, narrowing of the joint space, bone erosion, and ultimately leading to the fusion of the bone. Now, how to differentiate? What are the other conditions that can resemble rheumatoid arthritis? The differential diagnosis consists of the gout. SLE, what is the full form of SLE? Alright. Psoriatic arthritis, contractive arthritis, osteoarthritis and sarcoma. Osteoarthritis we have already studied, and we are going to study the other topics one by one. So you can easily distinguish between osteoarthritis and rheumatoid arthritis. Okay? Now we come to the treatment part. This is the last part. We are going to discuss the general management, the modern medicine management, and then the homeopathic management. Alright. So the treatment consists of the patient education of the disease and joint prevention. So first of all, you have to explain the patient about the disease condition, what is the disease condition, and what can be the severity, what are all other symptoms which can present, what are the articular manifestations, what are the extra-articular manifestations. This you have to explain to the patient. We have to give a physical and occupational therapy. Like physiotherapy, you have to prescribe to the patient, and other therapies, you also have to give assisted device. Assisted device that can help preventing more and more stress on those particular joints, like sticks and other things. Aspirin and NSAIDs can be given for pain relief. Okay. Intra-articular glucocorticoid, this is usually given because of the presence of great pain and inflammation and swelling. Alright, so you can give NSAIDs, you can give aspirin, you can give intra-articular glucocorticoids. In more severe cases, systemic glucocorticoids can also be needed when there is presence of more and more extra-articular manifestations. These are the DMARDs. DMARDs are basically disease-modifying anti-rheumatic drugs. These are very common these days. These are more safer than the drugs stated above and more effective. Methotrexate and sulfasalazine, this is usually given. And surgery is advised in case of severe functional impairment and deformity. Whenever there is more and more functional damage, there is more deformity, and the condition which cannot be treated by the above mentioned, then we have to go for surgery. So let's review this again. Patient education, this is very important. Next we have physical and occupational therapy, assistive devices, then aspirin and NSAIDs. Next is intra-articular glucocorticoids, systemic glucocorticoids, next DMARDs, disease modifying anti-rheumatic drugs, and then surgery. Now, homeopathic treatment, you all know, this is basically symptomatic treatment we are giving. Usually we are giving constitutional medicine according to the totality of symptoms, but some medicines can be given in the acute phases. We have arnica. What are the symptoms of arnica? As if beaten, the medicine after any kind of injury. Next, aurum metallicum. Aurum metallicum is given in case of especially depression case, when the disease is of long standing and the patient is getting depressed. Next we have belladonna. What are the signs and symptoms of belladonna? Red, swollen, throbbing pain is present and shifting pneumatic pain. Next we have calcaria calf. What are the symptoms of joint pain in calcaria calf? Nodes are involved. We have pain and inflammation in the joint, pain while ascending up and down. This is a very important symptom of calcaria calf. Then causticum. In causticum we have drawing pain. Alright. Pain especially affecting the muscles and tendons. Then calcarea floor. Calcarea floor is for nodes. Whenever the nodes are formed in joints. Dulcamara. Very important medicine for joint pain. What are the symptoms of dulcamara? Especially in downpour weather, if the joint complaints are there. Calibicron, this is useful in case of arthritic pains, different type of arthritic pains. Calicaf, this is another important medicine. What are the three important things that are present in the calicaf? Backache, and no, the three important things that is present in calicaf. There is trios, means three very important symptoms are present in calicaf. Can you enumerate these three symptoms? There is backache, there is three basic symptoms. When you start calicaf, you will come across these three symptoms. Just tell me in the next lecture what are the three symptoms of calicaf. Alright? Then calvia latifolia. What kind of rheumatism is seen in calvia latifolia? Ascending in leader column, descending in calvia latifolia. Very good. Pulsatilla, there is great changeability and joint affections. Rhododendron, especially in the rainy weather, stormy weather. Rustox, great medicine for early morning stiffness. The stiffness is better by motion. Ruta, with arthritis and the feeling of great stiffness and lameness. So this was all about rheumatoid arthritis. We have discussed rheumatoid arthritis in 3 lectures. We have discussed everything about rheumatoid arthritis. We have discussed about definition, etiopathogenesis, clinical features, investigations and management. Now in the next lecture we are going to start with another important disease of locomotor system, that is ankylosing spondylosis. So this was all for today. This session is powered by digital version 2.0 JV'n University. If you have any issues, please write in the comment box and I'll try to resolve it. So this was all for today. We are going to meet in the next lecture with ankylosing spondylosis. Thank you.